Hello everyone. We are now going to go over the flow cytometry plots from the peripheral blood of a 42-year-old woman who presents with anemia, thrombocytopenia, and numerous circulating blasts. Let's start with CD45 versus site scatter. We have a population that expresses bright CD45 and dim site scatter consistent with lymphocytes. And we have a population of granulocytes, which account for 29% of cells. They have very high site scatter and dimmer CD45 than the lymphocytes. And we do see a population here that has dim CD45 than the lymphocytes and kind of goes and merges with the monocyte gate and kind of shifting the monocyte gate onto the top. And these cells are labeled as blasts here. Like I said, in the history, there were numerous circulating blasts, and these blasts were 54% of all cells. Now let's see the phenotype of these blasts. They are positive for CD34. They express a partial CD33, and they're negative for CD117. They're positive for HLA-DR, in fact, going to a bright positivity. There is a partial dim CD15 expression. They are negative for CD117. They're positive for CD38 here, and they are negative for CD13. And you could see a partial CD64 expression, and they're negative for CD14 and a partial CD11B expression. And then they're negative for 16 and 56. They are negative for the T cell marker 3. They're negative for 71. They're negative for 2. So far in this page, in these tubes, we see that they are positive. They're expressing some myeloid markers, CD33 and CD64 and CD11B, a dim CD15. Looks more monocytic, and you know, the blasts are also kind of going into the monocyte gate if we remember the CD45 versus site scatter plot. And they express the immaturity marker CD34, and they are also positive for HLA-DR. When we look further, they're negative for other T cell markers. CD3 is negative, 4 and 8 are negative. There may be a dim CD7 expression. And when we go to the B cell tube, we see that they are brightly positive for CD19, and they have a partial CD10 expression. So the intensity of CD19 is pretty bright, and that intensity is usually seen in the B lymphoblasts. And B lymphoblasts are usually positive for 19 and 10. And if 10 is not brightly positive, or if it is heterogeneous, we need additional markers like CD22 or CD79A. Or if it is a tissue specimen, we can stain for PAX5. So here we have additional tubes, the cytoplasmic tube, which shows CD20 is negative here. In the cytoplasmic tube, we see that CD22 is partially positive, and TDT is partially positive. MPO is completely negative. This is again showing that the blasts are 19 positive and MPO negative. CD22 is partially positive again here, and CD117 is completely negative. So we do have a criteria that satisfies. We do have the B lymphoblastic criteria satisfied, like there is bright 19, heterogeneous 10, which is supplemented by a heterogeneous 22. So that kind of satisfies the criteria for the B lymphoblast. And also we have a population of blasts, like that is the subset of blasts that is expressing CD33, CD64, 11B, and partial CD15. So that kind of goes with the myeloid blast. So now your question could be like, can B lymphoblasts not express myeloid markers? Of course they can. There are some specific BALLs, for example, BL with 922, or even otherwise sometimes aberrantly they can express markers like 13 and 33, but they don't usually express markers like CD64 or 11B. Those are very, very rare. So when you see that here, until we got to CD19, we were kind of thinking that this is probably monoblastic type of blast. And also here we can see that the site scatter is much higher than what we see for a lymphoblast, and it's kind of going and merging with the monocyte gate. So it looks like the blasts are biphenotypic, that is, they are expressing both the lymphoblastic B lymphoblastic and the monocytic markers. So this is a mixed phenotype acute leukemia, B-Myeloid type. So to call something mixed phenotype, the blast should express more than one lineage markers, and to an extent that you will not be able to classify them into one particular lineage specifically. So for example, if it is B-myeloid, where the myeloid is just a regular myeloid blast, then you need MPO to be positive. And it's kind of even straightforward there when MPO is positive, because then it is B-myeloid. When the myeloid blasts are monocytic, then it kind of gets a little tricky, because the monocytic markers CD64, CD14, CD11C are considered more specific for, CD64 can be seen in myeloid blast also, but you don't see that in B lymphoblast. CD64, CD11B, and 11C, CD14, lysozyme, non-specific esterase if it is a tissue specimen or cytochemistry specimen. Those are considered specific markers for monocytic lineage, and you need at least 2 of them to be positive. And very bright 13 and very bright 33 are also considered more of a myeloid lineage marker. 117, 13, and 33 also helps in distinguishing myeloid from lymphoid blast. So here we have both the B lymphoblastic markers and the monocytic markers. So this satisfies the criteria for mixed phenotypic acute leukemia, B myeloid type. Here the myeloid component is monocytic component. And if you have tissue, or if you have the bone marrow biopsy specimen, you can also perform lysozyme or other monocytic markers to see their expression on the blast. So these are very rare. B-myeloid blasts are very, mixed phenotype acute leukemia itself are very rare. And there are a few types like B-myeloid, T-myeloid, B-monocytic like this one. And there are some with specific cytogenetic abnormalities like 922 or KMT2A rearrangement. So this one did not have any of those rearrangements by FISH studies. And one other thing you have to remember is when these patients relapse, they can either relapse as just ALL or just AML. And they can have either a lineage switch, or like one lineage can still persist after treatment. So you have to keep that in mind, and don't expect the relapsed specimen or your follow-ups in MRD to just have the same phenotype. It can just be one lineage blast. And when that happens, you can see additional expression of markers that are associated with that lineage and loss of markers that were previously positive from the other lineage. So when you write a report, you will just top line it as this percentage of blasts of ambiguous lineage identified, and you mention what lineage it is. In this case, it is B monocytic, and you will give the detailed phenotype of what are the markers they are expressing in each lineage. So here we have the same cluster of blasts where one side it is expressing the monocytic markers, and on the other hand, it is expressing B lymphoid markers. Sometimes you have 2 distinct clusters of monocytic and B lymphoblasts, or any 2 distinct lineage clusters. If that happens, you don't necessarily need 20% on each of those clusters to call it acute leukemia. Altogether, if you get 20% blasts, that's enough to call it acute leukemia. Thank you.